Good afternoon. I would like to invite you all to attend our surgical live presentation from the Lebanese University School of Dentistry at the Perio department. We are going to present a case of anterior 2 implants in the aesthetic zone. The patient presented with a chief complaint of a fracture on the upper right central incisor. Both teeth have been previously endodontically treated and they were fragile. There was recurrent decay on the left central as well. Both teeth were deemed unrestorable by the prosto department, so they were suggested that we extract them and place 2 implants in their place. The implants that will be placed are tissue level implants. We are going to be atraumatically removing both central incisor remaining roots and placing the implants at the same time, so immediate extraction, immediate implantation. The teeth will not be an immediate function. They will be restored with temporary restorations. And at the same time, if you notice, this patient has different gingival margins. The 2 central incisors are at a higher level than the canines on both sides bilaterally. So at the same time, a crown lengthening procedure will be done to place the gingival margin, both the central incisor at the same level of the canines, and the lateral incisors will be placed 1 millimeter below the centrals and the canines to create a better gingival profile for the patient and a better aesthetic smile design for her. The good thing with this case is that we have a thick band of keratinized tissue, so we can do the gingivectomies without worrying about losing the keratinized tissue. We will have more effective removal and a good profile after the crown lengthening procedure. We are currently doing the anesthesia, which will be a local anesthesia that is placed all the way from the first premolar on the right side to the first premolar on the left side. The patient has the temporaries already prepared, and the case is prepared for restoration after we're done. Usually with endodontically treated teeth, it will be harder to extract those remaining roots as the teeth become very fragile, and so we have to be very careful during extraction, using periotomes and using minor techniques to make the extraction as atraumatic as possible. Upon examination on the CBCT, we noticed that the buccal plates of bone were intact. There was no fenestrations or dehiscences present. We do not have any periapical infections or any radiolucencies present at the apices of the remaining roots. The palatal anesthesia and the nasopalatine is being given right now. The patient has no medical complications or compromises that may affect implant surgery at any point. The patient had been given some antibiotics the day before and this morning as well to prevent her from any infection or any problems. Okay, so we're currently trying the temporary restorations that will be placed afterwards. We're keeping them inside so that we can use the periotomes and we can easily extract the teeth. So these are the new temporary restorations that we are trying right now. The temporary restorations that were placed on a better gingival inclination and a better profile. You can see that there is a slight opening on the lingual side. We are just adjusting the patient's, right now, the patient's chair so that you can get a better, clear view of the case. So those new temporary restorations were already pre-prepared, and we opened them from the inside so that we can add acrylic material in the end and reline them. So they were prepared before the surgery to make it easier after the surgery to make the restorative phase very quick and easier for the patient. So this will be used for relining at the end of the surgery. It's very important that the margins be flush, that they be completely smooth, and there is no irritation to the marginal tissues of the soft tissue around the implants that will be placed. Especially that we are placing tissue level implants in this case. So we will start by measuring the gingival levels of the central by the canine. So the canine and the central will be at the same level. The zenith position will be adjusted so that it's slightly distal to the midline of the canine. And as we see over here that we have about 2 millimeters maybe on the canine portion, about 1 millimeter on the lateral that have to be adjusted so that we can get a better gingival proportion between the canine central and lateral incisors. We do have some sulcus depth, so we are measuring right now to sound where the bone is and where the cementoenamel junction is so that we know how much soft tissue we're going to be removing and if we have remaining biologic width without doing a crown lengthening procedure. If a gingivectomy by itself will be sufficient for this case. We will be using a 15C blade to start with the gingivectomy. As we see, we have some bleeding points which will indicate the level where we're going to be doing our gingivectomy procedure. We're going all the way to those points which are the bleeding points from the cementoenamel junction to the bone. So you can see that there is a distal zenith on this canine. It's not a straight line margin. The distal zenith is between the slightly distal to the midpoint of this canine. So the orientation is to the distal. When we go to the lateral incisor, we're going to be making a horizontal or flatter incision. There's no zenith position at this site. we are an internal incision is made in the sulcus so that we can be able to remove this band of gingiva that we just cut. So we're using a surgical curette to remove this tissue, this band of tissue that we just excised. And you can visualize now that the canine appears as if it's a better size of this tooth and a better aesthetic shape of this tooth as well. We're going into the beveled incision on the lateral incisor. You can appreciate the wide and horizontal margins that are being created, all the way to the points which we created with the bone sounding procedure. The excision is done already with a clean cut. We're doing our measurements to make sure our canine is at the 11 millimeter mark. And then the lateral incisor is almost at the 9 millimeter mark or 10 millimeter mark almost. Going to the next side, we're going to do the same measurements, which are the gingival level measurements according to the central incisor, then going into the bone sounding again, creating our bleeding points. So we have about 2 millimeters of supragingival tissues almost, so the SGT in this case is about 2 millimeters. We're going to change our blades. Every time the blade will touch the tooth, it's going to become dull, so we need to change the blade as frequently as possible to create this clean cut that we created on the right side. So we have some bleeding. What we're doing is we're placing some anesthesia points to do some vasoconstriction and decrease the bleeding at the site. So now we're going back to the intracellular incision to dispatch this tissue and remove it without any tension, without any okay. So what we're doing is we did the intracellular incision again, and the intracellular incision will allow us to remove this tissue without any dehiscence or any fibrous tissue attachment. So what we're doing right now is the beveled incision on the canine portion, and we're creating it exactly like the right side portion, whereby the zenith is created and the internal cellular incision is done as well. This will be on the same level as the central incisor, 1 millimeter almost higher than the lateral incisor gingival margin. The curette will be used again to remove this excised tissue. We have a thick tissue biotype in this case, so it's a bit hard to remove this excised tissue. We're going back with the curette and making sure that we have a clean cut. Okay. So we're just in our last step of the removal of the excess tissue. The gingivectomy procedure is now completed. We're now doing the intracellular incision to open our envelope flap. This will be a full mucoperiosteal flap. The flap will extend from the right canine side to the left canine side. Full mucoperiosteal flap, no partial thickness in this case. The papillas will be elevated with the flap itself. We will start by elevating the papillas first, placing some pressure on the papillas with the fingers to avoid the slippage of the periosteal elevator, to avoid tearing of the soft tissue. With the root canal treated teeth and endodontically treated teeth, we might have some scar formation or some fibrous tissue adhesions. So we're going back with our blade to make sure that we have clearance, and we're going all the way to the bone so that we can elevate a clean and full mucoperiosteal flap without any tearing or dehiscences to the periosteum. The periosteum in this case will act as a blood supply to our graft material or our implant that will be placed on the side, so it's very important to keep it intact. As I understand, there's been some technical difficulties. We're making the voice a bit higher right now, so I hope that you're all be listening or hearing after we increase the voice. The volume is being increased, I hope. Okay. Always use a moist gauze, a gauze that it has been impregnated with some saline. This will avoid tearing of the soft tissue and adhesion of the cotton into the flap material. What we can see is that the bone is being exposed right now. We're elevating beyond the mucogingival border, starting of course with the papillas, making sure that the papillas are completely intact, and elevating all the way to the mucogingival border. We can see some fibrous tissue and some granulation tissue around the right central incisor, which has been the cause of the problem and the chief complaint of the patient, and this is where the fracture happened when there was the ceramic crowns on those endodontically treated teeth. We're extending our flap now to the palatal aspect, and we're doing also a full mucoperiosteal flap, including the papillas on the palatal aspect. The full mucoperiosteal flap on the palate will also extend from the right canine to the left canine. We can appreciate from this image that we have badly decayed central incisors. We do not have any crown left on these central incisors, no ferrule effect, and no possibility for restoration of those two central incisors. The flap has been elevated from both the buccal and the palatal side. We can see the clean periosteal flap elevation, and the bone is clearly evident in this case. There is some bleeding due to the granulation tissue and the fibrous tissue that's present because of the infection and the fracture at the right central incisor. Some root planning and removal of the granulation tissue is being done right now. We're using our Gracie curettes to do our scaling and root planning in this case. We will start with the crown lengthening, so we're going to remove the excessive bone on the on the lateral and the canines, so that we can recreate this biologic width, so we do not have any violation of the biologic width after we close the flaps. This will also prevent the relapse of the growth of the soft tissue that will come back if we do not remove the bone, and create a space between the cementoenamel junction and the bone level, which is about 2.6 millimeters. A small round burr will be used for bone removal, for ostectomy. We will be using the blunt end of the periosteal elevator to reflect the flap without creating any tension on the flap. So just making sure that there is enough irrigation and water so that we do not overheat the bone and create necrosis. We are doing the crown lengthening procedure prior to the implants, so that we do not keep the implants exposed to the oral cavity, so that once we place our implants, we're able to close the site and suture immediately. So the crown lengthening has to be done prior to the implants. Now we're doing our best not to touch the tooth surface with the round burr. The round burr has to be a diamond round burr that's going all around the margins of the cementoenamel junction, touching the bone levels. We're trying to remove about 1.5 to 2 millimeters of the bone level, so that we can create an efficient biologic width to prevent the relapse of this soft tissue. After performing this ostectomy procedure, we will proceed with the osteoplasty procedure, which will remodel this bone around the tooth surface and create a blended surface, so that the soft tissue can close without tension or without any ledges or any gaps. If you are just joining us right now, we would like to welcome you again to the case presentation, which is a live surgical presentation from the Lebanese University, from the perio department. This patient came in with a chief complaint of a broken right central incisor that was previously root canal treated, with 2 ceramic crowns placed on the right central and the left central incisors. Both teeth were previously root canal treated, thereby becoming more fragile and more prone for fracture. The right central incisor, it was decided that needs extraction because the fracture was below the bone level. Whereas the left central incisor, once the crown was removed, there was some decay. There was no feral effect for another crown to be made. So both teeth were deemed prosthetically non-restorable. It was decided that they should be removed. The decision was made to remove both central incisors and replace them with immediate implants. In this case, we're going to be placing 2 tissue-level implants. And at the same time, since the gingival margin of the central incisor was higher than the canines on the right and the left side, so crown lengthening procedure was also decided. The crown lengthening will be done on the canine and lateral bilaterally. Once we did our gingivectomy procedure with the soft tissue and we removed the excess soft tissue because we had a very wide band of keratinized tissue, we opened a flap. And because of the bone sounding previously showed us that the bone level was at the cementoenamel junction. So if we kept the bone level at the cementoenamel junction, we will get relapse of this tissue and rebound of this tissue, thereby deeming our crown lengthening procedure not efficient. So we have to open a full mucoperiosteal flap, adjust the bone levels around the lateral and the central, around the lateral and the canine. And the bone levels will be about 2 millimeters below the cementoenamel junction, going from the mesial side to the distal side, all around those teeth. After the ostectomy is done with the round burr, what we will do is we will do some osteoplasty, which will adjust the shape of the bone, creating some scalloping and more harmonious appearance of the bone so that the soft tissue can follow the bone appearance and the bone architecture. The crown lengthening procedure is done prior to the implant placement so that we do not keep the implants exposed in the oral cavity while we perform the crown lengthening on the right and the left sides. The ostectomy is almost completed on the right side. And now we're moving on to the ostectomy part on the left side. On the left side, we do not have as much bone removal as the right side. We can see that there is some gap between the cementoenamel junction and the bone. So we'll only remove about 1 millimeter on the left side, whereas on the right side, we removed about 2 millimeters. We're always making sure that there's copious irrigation and that there's a lot of water that's supplied to the site to prevent the necrosis of the bone. The bone removal is done in a scalloped way, which is uniform from the mesial side to the distal side without creating any bony dehiscences or any fenestrations, making sure that it's in a slow manner and that's where the touch is not too deep and not too aggressive so that we can keep the bone attached to the root surfaces. Very gentle pressure with the round burr. So now we're creating the scalloping and the roundation. We're making sure that there's no ledges or no protuberances in the bone. The roundation of the margins is very essential, and scalloping of the margins is very essential for adaptation of the flap later on. Again, removal, doing some root planning of the roots and removal of any granulation tissue, as well as adjusting the bone levels and making them flush and knife edge to the surface of the roots. Now we're going to be using the periotome to remove any periodontal ligament attachments and any adhesions to the remaining roots at the site. The periotome is very essential so that we do not widen the bone and we do not create any trauma on the buccal plate of bone, which will be crucial for our success of the implants in the aesthetic area to prevent any recession of the soft tissue at a later point. A straight periotome is being used in this case. We're going in the buccolingual direction. We're starting at the distal side of the right central incisor. The pressure has to be inside the socket, not on the teeth themselves, and not on the buccal plate of bone or lingual plate of bone. Very gentle movements in a buccolingual direction. The root is moving at this point, so we can feel that the root is moving. What we're going to do is we're making sure that the periotome is going all the way to the apex of the root itself. Once the right central incisor started moving, we moved on to the left central incisor, and we're doing the same motion, buccolingual, starting from the distal side and then moving to the mesial side. Once we feel that the root is slightly movable, then we can proceed with our remaining root extraction forceps to remove it atraumatically. The importance of the periotome is to remove any soft tissue adherences and any periodontal tissue attachments all the way to the apex of the root so that we do not use too much pressure on the buccal and the palatal plates of bone. Root canal treated teeth usually fracture a lot during extraction, and they are very fragile and friable, so it's very important to atraumatically remove them as much as possible. If they do break, you have to open a wider flap and try to go in with burrs or with the remaining root elevators so that we can remove them without tension. But in this case, we can see that the roots are moving. We're using a straight elevator. So we can appreciate the movement of the root of the tooth, and the right central incisor has been removed. We are examining the buccal plate of bone and the socket. We can see that there is some bleeding. We have very thick buccal plate of bone, an intact buccal plate of bone. There is no fenestrations or dehiscences or any defects in the bone. On the palatal side, we're drying up the area so that we can see the palatal side as well. So we're going to reflect the palatal flap so that we can see the socket itself in all directions. We're trying our best not to remove all the blood at the side, so we're trying not to suction a lot. And we can see that the palatal and the buccal walls are on the same level. We have an intact socket on all four sides with very thick soft tissue and very thick buccal plate of bone. Adding some anesthesia on the palatal to decrease the bleeding, create some vasoconstriction. Proceeding with the straight elevator on the left central incisor. Using the remaining root tip forceps with a circular motion to remove the remaining root. So we're doing a roundation, like a circular movement, to remove it as atraumatically as possible without the buccolingual rotation of the root. You can see that the other remaining root has been removed as well. We will examine both sockets right now. Once we elevated the palatal flap, we can appreciate that the palatal walls are present, the buccal walls are present, the margins of the bone is intact. There is thick buccal plate of bone on both the right and the left central incisors. We want to see the levels of the bone on the central with respect to the lateral incisor and the cementoenamel junction of the neighboring teeth. We are almost 2.5 millimeters away from the cementoenamel junction of the neighboring tooth. And the implant will be placed directly on the bone level that is present at this point. So the level of the bone, which is 2.5 millimeters away from the cementoenamel junction on the neighboring lateral incisor, that is where the level of the implant will be. Dr. Susanna, if you can show us the remaining roots, just use a plier and remove one of the remaining roots and just show it on the camera, please. So this is the right central incisor, and we can see that the whole root is intact and the tip is present, so there is nothing remaining inside the socket. The whole root has been removed. And we can also see that there is only the root that's present. The crown is almost gone because of the fracture, and the other central incisor is also intact completely. We are going into the sockets, and we're doing some curetting of the socket so that we can remove the granulation tissue that was present because of the periapical because of the infection on the side. We're making sure that there is no granulation tissue present and that the walls are intact. We can hear the bone on both the right and the left central sockets. This will indicate that there is no granulation tissue remaining and will allow us to start with the implant drilling sequences. Before we start any implant procedure, we have to take a look at the kit, make sure that all our armamentarium is present, and prepare ourselves so that the sequence is very simple and rapid. We are using Straumann tissue level implants in this case on both the right and the left central incisors. بالبيريو بروب قديش عندك ديستانس جوا بقلب الساكت بكل وحده بالبيريو بروب. We had already measured the site on the CBCT that was done previously, but we will use our perioprobe as well to go into the socket and measure the coronoapical height of the socket. So we're going in with our perioprobe and we're measuring all the way from the bone levels on the crest to the apex of the root. And the measurement is almost 8 millimeters on the right central incisor and 10 millimeters on the left central incisor. What we need to do when we're doing an extraction and immediate implantation is that we need to go in a palatal direction. We do not go in exactly the same direction as where the root is, so that we can engage more of the palatal bone on the site, and it will give us initial stability. So we're going to go slightly with the tip of the burr to the palatal aspect so that we can engage more bone. But at the same time, we have to make sure that the head of the implant is going with the occlusal direction with the rest of the dentition, and that it will occlude with the opposing dentition in a proper overjet and overbite. So we're directing the head in the middle of the occlusal surfaces of the neighboring teeth, but we're going with the tip of the burr to the palatal aspect to engage the buccal plate of bone, to engage the palatal plate of bone, excuse me. Dr. Maalouf, can you let us know how much you're going to be drilling? Like, how deep are you going to be drilling? We're going to be drilling to 13, so the implant is the implant length is? The implant length is 12 millimeters. Currently in this socket we have almost 8 to 10 millimeters, depending if it's the right socket or the left socket, but both of them we're drilling to 13 millimeters so that we can get primary stability from the apex, which is the 2 to 3 millimeters additional drilling aspect, and from the palatal surface as well. So the tip of the head of the head of the implant will be directed more buccally, but the tip of the burr will be at the palatal aspect. So when we're putting our guide, after we did our pilot drill, what we notice is that the guide pin is placed, okay? So it's placed slightly towards the palatal. We're going to engage it a bit to the buccal, and we need to go a bit deeper on this implant site. So the shoulder of the implant will be at the buccal level. So when we're looking for our reference, we're looking at the buccal crestal bone, and the markings on our implant drill, which is the 2 millimeter twist drill, will be to the 13 millimeters when referenced by the buccal plate of bone. Because the buccal bone, again, as we said previously, is about 2 millimeters away from the cementoenamel junction of the neighboring teeth. Now we're placing our guide again, and we are at the level that we want it to be. It's 13 millimeters with reference from the buccal plate of bone. It's going slightly towards the palatal to get us some engagement and some primary stability, and at the same time it is in line with the neighboring teeth, with the occlusal surfaces, and with the arc of the neighboring teeth. On the left central incisor, we're using our 2 millimeter twist drill. We're using the buccal plate of bone also as a guidance, and we're going to 13 millimeter marking on our 2 millimeter twist drill. Once we're done with our 2 millimeter twist drill, we're going to move to the next burr size, which is the 2.8 millimeters. And the 2.8 millimeters will also go all the way to the 13 millimeter mark on both sides. Once we have our direction and our guide placed, we can use the guide on the right side to help us on the left side, so that we can always be parallel. Both implants will be placed parallel to each other, and the emergence profile will be parallel, making it easier for the restorative dentist. So once we look into the socket, now we're going to appreciate that there are almost two sockets. There's one on the palatal side, which is the drilling side, and there's our original socket. And we have to make sure that we do not slip while we're drilling and go to the original socket, which will give us less engagement and not improper orientation of our implants, and as well buccal plate bone loss and some recession and dehiscences on the buccal plate. So always make sure that you're going towards the palatal. Okay. 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 So what we're doing now is we're using the guide to check if we're going to place a 4.1 millimeter implant, or we're keeping it as a 3.3 millimeter implant. So after placing our guide, we noticed that we do not have enough gap between the buccal and the implant to place the bone. So to prevent the collapse of the buccal plate of bone, we decided to keep it at a 3.3 diameter implant. And the 3.3 diameter implant will give us enough gap and enough support for our buccal plate of bone, and we can add some bone graft material at the site so that we can prevent the bone loss on the buccal once we have the remodeling, because every single time we do an extraction, there will be a remodeling of the buccal plate of bone. So we're going to use two 3.3 diameter by 12. So the 3.3 by 12 millimeter implants. So we're using the rock solid implants. So we're using the 3.3 by 12 millimeter rock solid tissue level implants in this case. These are the implants that will be placed at the site. So this is the rock solid 3.3 by 12 millimeter Straumann tissue level implant. The implant is directed by hand. Directed towards the palatal aspect, exactly where we were doing our drilling. So we have to make sure that we have some primary stability, and we do not use the handpiece in this case. The hand manipulation will give us better orientation and more stability and less possibility for fracture or dehiscence of the buccal plate of bone. We are using the wrench right now to insert the implant, and as we said, the level of the implant will be placed to the buccal plate of bone. So our reference is the buccal plate of bone. We're using the torque wrench to insert the implant by hand. We can appreciate that the implant is being placed to the palatal aspect. And you can appreciate that we do have primary stability of this implant as well. You can see on the buccal aspect that the level of the implant, that is where we're going to stop. So once we stop, we stop seeing the yellow marking almost. We start seeing the blue marking at the buccal plate of bone. That is where we're going to stop. The purple or blue? Okay. So now we are at the buccal plate of bone. We remove our torque wrench and we remove our handle. We are keeping the mount as a direction for the other implants. So we're comparing the level of the implant to the cementoenamel junction of the neighboring tooth, and we are 2 millimeters away from the cementoenamel junction of the neighboring tooth. So this is just a confirmation that our implant level is at the buccal plate of bone, crestal aspect of it, and it is 2 millimeters below the cementoenamel junction of the neighboring tooth. So this will help us have a scalloped margin, a proper biologic width, and a proper soft tissue profile and emergence around this implant. While the mount is placed, we are placing the other implants so that they are parallel to each other in a proper direction. We're also inserting them by hand. We start off with the mount and the hand wrench, and then we move to the torque wrench that we can complete the insertion of this implant. As you see from the motion of the fingers right now that we do have some tension and that the implant is being inserted with no force and pressure, but at the same time we do have some primary stability and we have some tension at the bone area. We're being very careful to make sure that the level of the implant is at the buccal crestal bone level. So after placement of this implant, it was noticed that we need to drill a bit deeper at the palatal aspect. So we removed the implant by hand and we're drilling to a deeper point, going to the palatal with a 3.3 millimeter drill and reinserting the implant by hand to a deeper level at the palatal aspect. Torque wrench. Because we changed the direction slightly of this implant on the left side, there was a slight mesial inclination of the head of this implant. To change it to the distal inclination and make it more parallel, the change of direction made it harder to insert the implant in the first place. Now what we're doing is we're using the torque wrench so that we can make sure that it is stable inside the alveolar bone that we created, or the socket that we created for the implant. We're looking at the buccal aspect and we're seeing that we are at the level where we want it to be. We look at the neighboring cementoenamel junction and we check that it is 2 millimeters away. We remove the mounts of both implants. You can see that both implants are slightly towards the palatal and we have a gap between the implant and the buccal plate of bone. This gap will be filled by bone, by particulate bone. So we will be attaching the abutments right now to the implants, sir, to the implants. So we're connecting the abutments to the implants. The abutments that we're placing are 5.5 millimeters in diameter. They're direct post abutments. We are we are looking for the driver to place the abutments right now. So we will be placing 2 abutments on the right and the left central incisors. If you are joining us right now, what we did is a crown lengthening procedure on the right side and the left side of the lateral and the canine. We just extracted atraumatically the 2 central incisors that were non-restorable and endodontically treated. The extraction was done atraumatically using a straight periotome and then straight elevators. After atraumatically removing the 2 central incisors, we used a curette to remove all the granulation tissue from the sockets. After making sure that the bone is sound and there is no granulation tissue left, what we did is place we used a 2 millimeter twist drill to go to the palatal aspect with the direction of the occlusal surfaces as well. And after placing 2 implants by hand and using the torque wrench to make sure that we have initial stability, we are placing our 2 abutments, which are 5.5 millimeter in diameter. The abutments are being screwed right now to the tissue level implants that we placed. The implants were 3.3 millimeters in diameter and 12 millimeter in length. When we were doing our drilling, the right socket was 8 millimeters in length from the coronal aspect to the apical aspect. So while doing the drilling, we went to 13 millimeters using the buccal plate of bone, the crestal portion, as a reference. So the implant has to be drilled, the drilling sequence has to be deeper than the socket itself so that we can engage in the apical portion of the socket. Two straight abutments have been placed. The abutments are 5.5 millimeters in diameter. We can appreciate the parallelity of both abutments and the proper direction with the arc, the occlusal arc of the upper anterior teeth. We are going to prepare right now for placement of our bone graft material. A particulate bone graft will be placed to fill the gap between the implant and the buccal plate of bone. This will prevent the collapse of the buccal plate of bone during the remodeling of the bone after extraction. I'd like to remind you that the temporary restorations have been prepared prior, and they have been prepared, and the inner surface has been relieved so that we can add some acrylic restoration material and reline those temporaries. It will be a fast reline because we already prepared them beforehand. After preparation of the temporary restorations, that's when we're going to add our bone graft material and suture the area. We're preparing our resin acrylic material so that we can add it to the inner surface of the 2 temporary restorations that have been prepared previously, so that we can do the relining to the margin of the abutment teeth that are placed. The acrylic material is being mixed right now. We want a thick consistency so that we can get complete dryness of the material in a fast approach. All we're doing is we're relining the previously made shells or the previous temporaries that were made prior to the surgery. Adding our acrylic temporary restorations. So we're adding our acrylic material into the inner surface of the relieved temporaries. These are the shells with the temporary material placed inside. Okay, you can appreciate the acrylic material that was placed and filled inside the shells of the two temporary restorations with a very thick consistency. So we want it to be in a very thick consistency to model it to the shape that we want it, and for it to fast, so that it can dry in a fast manner. We don't want it to stick to the area. We're placing our temporary restorations, placing some pressure on the abutment teeth, and the excess will be removed. We do have an opening from the lingual side which will remove the excess acrylic material, and we're adapting the acrylic material to the abutment surface so that it's flush to the abutment surface with no gaps or no possibility for plaque retention and for leakage of bacteria. This will help in adaptation of the soft tissue and better emergence profile of the soft tissue. It's very important for it to be flush with the abutment, with no gaps and with no ledges or protuberances on the acrylic material. So we don't want any ledges. Okay. We're adapting the flap to the surface, and we're waiting for the acrylic material to set completely before removing it. This will give us the shape of the inner surface of the soft tissue. Will allow adaptation of the soft tissue to the temporary restorations without gaps so that we don't get any seepage of the blood on the sides. Scalloping of the soft tissue on the temporary restoration is very important for long-term soft tissue profile. The patient is closing right now to make sure that there is adaptation of the provisionals to the abutments. The patient has a crossbite, so we're trying our best to create an edge-to-edge as much as possible. We cannot create a normal overjet and overbite in this case, but if we can get an overjet kind of case, it would be preferable. Okay, so we removed the acrylic temporary restoration, and we're readjusting it and making sure that it's well adapted. We might need to reline some of the margins of this restoration. So we're going to adjust it before and then see if it needs any reline. We're removing the palatal flap as well to make sure that it's adapted to the palatal abutment. So we're making sure it's adapted to both the buccal and the palatal aspect, and that there is no gaps or no ledges or overextension of our provisional restorations beyond the margins of the abutment itself. Any extension of the restoration might lead to bone resorption, and bone resorption during the healing process will be detrimental to our case. As you see in this case, we're closing the site with a gauze so that we do not get any shards of the acrylic material. So what we're doing right now is adjusting the margins and the finishing of the temporary restorations, removing any excess acrylic resin that is present, making the provisionals as smooth and as flush as possible. This will help with the adaptation of the soft tissue and prevent any bone resorption. We're trying in the temporary restorations intraoral. We need to relieve. Susanna. Again, we're going for more of an edge-to-edge kind of case with the upper and lower overjet. The patient has a crossbite occlusion. We're doing some final relining of those temporary restorations right now. Need to make sure that the contact point in between the two centrals is slightly open so that there is no accumulation of plaque and that the papillas in between the two central incisors have some space for them to breathe and that there is no violation of the biologic width at the side. The extension of the provisional restoration will be at the margin of the abutments on both the right and the left side. The margin of the abutment on both the buccal and the palatal aspect have to be completely flush with no openings or overextension of this acrylic material. our opening to make sure that there's no excess material coming out from the palatal side, and to adjust the finish lines on both the temporaries from the palatal aspect. This will need some time for it to set, so we're making sure that we're pressing so that we are exactly where we want it to be. We don't want any movement. This movement will create some gaps because of when the temporary restoration is drying up, it might create some viscoelasticity, and this will change the shape of the provisional restoration. There will be some gaps between the margins, so we make sure that we are pressing really hard and we're all the way to the margin of the abutments on both sides without removing our fingers until the setting of the material. We remove it slightly and put it back in so that we don't have any undercuts that might prevent us from removing it after the setting of the material. So we check that there's no undercuts and there's no excess, and that it's easy for us to remove it and place it back. It is a slow setting material, so it will take some time for it to set. Adjustment of the provisionals is being done outside the oral cavity. We're going around the margins of the restorations to adjust the finish lines. The final touches of the acrylic restoration is being done right now. Then the polishing will be done. And this will create a hygienic temporary that will be placed on the two tissue level implants that were just placed, and the two abutments that were attached to the tissue level implants. As you see, adjustment of the temporary restoration takes time, so it's crucial that we have a shell of a temporary restoration done prior to our surgery. So using a straight handpiece and finishing burrs, diamond burrs, we're finishing our temporary restorations. We will use a disc right now, and the disc will help us to open the embrasures and make sure that there is sufficient space between the two centrals. For the proper seating of the interdental papilla between the central incisors. So the embrasures are being adjusted at this moment using the disc. This will create a sufficient contact area for the papilla to grow and to give us a proper emergence profile of the soft tissue, scalloping of the soft tissue, the gingival margins, and the papilla site. So always consider that the zenith point at the central incisor is slightly distal to the midline of this both central incisors. So once we place our temporary restorations, we need to adjust to that fact as well. Placing the temporary restorations intraoral, and we're looking at the gingival margins. Looking at the emergence of those two crowns with the occlusal surfaces of the neighboring teeth. And you can see that we have a proper aesthetic appearance, proper emergence profile, and we have sufficient space for the interdental papilla. We will be polishing our acrylic temporaries right now. Using both the soft and the rough polishing bars. Polishing both the buccal, the palatal aspects, as well as the finish line area of the temporary restorations. The final step after the temporary restoration adjustment would be adding the bone particulate matter in between the gap of the implant and the buccal plate of bone, and then suturing the site. Since we have thick buccal plate of bone and thick soft tissue with intact periosteum, we will not be placing a membrane. In this case, it will only be a particulate bone graft to fill the gap and prevent the collapse of the buccal plate of bone. Checking again the margins and the occlusion. You can see the emergence of the crowns with the neighboring teeth, the correct roundation and emergence. And we can see that we have an edge-to-edge bite with the lower anterior teeth. So we have an edge-to-edge kind of occlusion with the lower anterior teeth. Because this patient, again, is in crossbite, so her occlusion is a crossbite occlusion, we are trying to change this relationship and try to do it into an edge-to-edge kind of relationship. So now we're going to add the bioos, the bone graft material. So this is a xenograft material that would be added. Xenograft material is being prepared right now. The bioos will add some saline to the bioos so that we can make it more moldable and place it in the gap between the implant and the buccal plate of bone. A sterile appendage is being placed and the bone graft will be added to the saline. In this case, we do have an extraction socket, so we already have bleeding in the site. There's no need to do any decortication at the buccal plate of bone because we have bleeding at the site. Reflection with the blunt end of the periosteal elevator to expose the area between the implants and the buccal plate of bone. Adding the particulate bone graft, which is a xenograft material, bioos. It's bovine in origin, small particles. We're packing it in the gap between the implant and the buccal plate of bone. You can appreciate that there is some bleeding, which will be dried off with either very carefully with the suction or with the tip of the gauze itself. There is no need to overpack and overcompact this bone particles because overcompaction will lead to suffocation of the blood supply at the site. So we try to place it as neatly as possible and as loosely as possible. Since we have a thick buccal plate of bone again and a thick soft tissue, and we do have a socket area where the bone will be contained between the implant and the buccal plate of bone, there is no need for a membrane that will help in the containment of the particulate bone graft that we are placing. And this particulate bone graft will decrease the amount of remodeling of the buccal plate of bone and allow for better healing and better support of the buccal plate of bone, thereby supporting the soft tissue and preventing collapse of the soft tissue. We're drying off the site with a wet gauze to make sure that the bone is in the area where we need it to be and to take a look and see if there's any additional bone graft that might be needed at the site. Removal of the excess bone graft material in between the two implants and at the periodontal ligament area of the neighboring dentition. We will be cementing the temporary restoration right now. The temporary cement that will be placed has to be in minimal amount, and we have to make sure that we remove all excess cement because cement will lead to bone resorption and bacterial accumulation and microbial leakage. We are cleaning the temporaries right now from any blood that was present at the site. Mm. Minimal amount of temporary cement is being placed with a small spatula. Drying off the abutments, packing the bone, the areas where you want it to be, making sure that the palatal and the buccal mucoperiosteal flaps are elevated so that once we place our temporary restorations, they go all the way to the tip of the abutment area and they're flush with the both abutments on the right and the left side. Checking the palatal aspect and the buccal aspect to make sure that there is no excess cement coming out. There is no cement coming out from either side. We're looking for some suture material. Suture. We're using our Castro Viejo to suture the site. Polyglycolic material, resorbable. Polyglycolic material is a 14-day resorbable suture material. It will be used in this case. Simple interrupted sutures will be placed. The suture will be about 3 to 4 millimeters away from the papillary margin in the papilla area, going all the way to the palatal, engaging the palatal aspect and going back to the buccal area to close it. Try our best to be away from the margin of the flap so that we can engage more soft tissue, which will prevent the breaking of the suture later on. This will give us more support and more closure without tension of the flap. Going under the embrasure area and back to the buccal aspect. And making sure that the knot is on the buccal area, not on the tip of the papilla, but in the middle of the papilla without any tension. A simple interrupted suture is being used in this case. Since we already did the ostectomy and osteoplasty prior, the osteoplasty will allow the proper adaptation and the scalloping of the soft tissue without any gaps between the cementoenamel junction and the soft tissue profile. So we will have a flush soft tissue to the tooth surface, and this will prevent the seepage of the blood and will allow for better healing and better adaptation and prevents the bone resorption later on and remodeling. We will add some anesthesia for the patient right now, which will decrease the bleeding, make it easier for us for the field of vision and for the patient herself. So to recap, the important aspects of this case is make sure that you check the gingival margins of the neighboring teeth if you're doing implants in the aesthetic zone. If the gingival margins are at a discrepancy, you might be needing to do a crown lengthening procedure and not just an implant procedure. Because in this case, if we would have done just an implant procedure and the patient would have thought that there was some remodeling or something wrong with the implants because the implant crowns will be longer than the lateral and the canines, which are neighboring to those two implants. So with the diagnosis process, noticing that the two lateral and canines needed crown lengthening prior to the implant would help with the gingival profile and the gingival levels and give the patient a more aesthetic smile. The other thing that we should notice is that always adjust the bone levels on the neighboring teeth before doing your implants, because in this case we needed to check the buccal, the crest of bone on the buccal. The level of the crest of the bone of the buccal should be 2 millimeters away from the cementoenamel junction of the neighboring teeth, which gave us the indication and the reference of where we're going to place the level of our implants in this case. Then what we need to adjust and make sure that the buccal plate of bone is intact, and if we need to add any particulate bone graft, the particulate bone graft will help in prevention of the collapse of the soft tissue in the bone. The implants have to be placed slightly to the palatal and to engage a bit to the apical portion as well, which will give additional stability of this implant. Do not follow the shape of the socket itself, because if we follow the shape of the socket itself, we would have created some buccal bone dehiscence and fenestration and openings in the buccal plate of bone, and eventually resorption and soft tissue collapse, as well as the lack of stability of the implant itself. Always go under the embrasure area and all the way to the buccal. Having the provisional restorations prepared beforehand also helps, as the provisional restoration adjustment takes more than the surgery itself. So the time to prepare the provisionals takes more than the surgical procedure. As you see, we're doing our best to adjust the flap so that there is no tension at all to the flap itself. The tension will lead to failure of the procedure. Going to the base of the papilla to start our first knot, not the tip of the papilla. Going under the embrasure site. It's very important that those embrasures between the two centrals have been opened widely to allow for the soft tissue adaptation and the papilla adaptation at the site. Going into the palatal. And in these cases, you would want to use a wide needle curvature, because if it was a short needle curvature, it would have been difficult to insert underneath the contact areas and go all the way from the buccal to the palatal aspect. The knot is always done on the buccal area, not on the tip of the papilla, but on the buccal portion. see the pull and the closure of the papillas. We're almost done. There's one more papilla to close, and you can see the lack of tension at the papilla side. Some hydration of the site is being done. And placing the last suture in between the canine and the premolar, going at the base of the papilla again, about 4 to 5 millimeters away from the margin, going underneath the contact area to the palatal aspect and engaging the palatal soft tissue. You can see the tight adaptation of the soft tissue on the 2 central incisors that were restored with the implant restorations right now. And there is no gap in between the soft tissue and the provisional restorations. The bone graft has been completely contained inside the socket area, contained between the implant itself, the implant body, and the buccal plate of bone, with the complete closure of the mucoperiosteal flap, having the periosteum completely intact, which will support the healing of our buccal plate of bone and our bone graft material and the implant. There is some slight cement on the right central incisor. Bone graft? Okay. Just making sure that this is resin and not temporary cement. So this is from the resin material. It's completely adaptable. There's no excess cement on this site. Using a moist gauze, we're adapting the soft tissue, making sure that there is no gaps for the seepage of the blood. These are the final restorations, cemented in place. The area is sutured all the way from the right canine to the left canine. The gingival marginal levels of the centrals are at the same level as the canine itself, and the lateral is slightly lower. We can appreciate the tightness of these sutures, but not too tight, so there's no pressure, but there's adaptability of this soft tissue. There is an edge-to-edge component of the overjet because the patient has a crossbite, so we try to adjust it in that manner. We would like to thank you for attending our live surgical demonstration from the perio department at the Lebanese University. I hope you enjoyed our presentation, and we would like to take any comments or any questions that you might have on the internet or the Facebook page if you have any questions. Dr. Maalouf, thank you for the case, and Dr. Susano. Now, Fadi, thank you so much.